The outcomes are very different if patients are progressing on chemotherapy rapidly. We know that this group of patients is generally in trouble and their outcomes are worse than those that have a response or have stable disease with chemotherapy. And so this group of patients, I think we need to think critically about what we do for them as a second-line drug. Do we give them immunotherapy? Do we give them docetaxel ramucirumab? What's going to add meaningful improvement in their outcome is very important. I consider switching therapy if they have disease progression and they're symptomatic, or they're not tolerating the frontline regimen. All of those factors go in. I would say in a squamous cell patient, it's very clear-cut most of the time. Not so clear-cut in the adenocarcinoma population, but in the squamous cell patient, these patients, you know when they're progressing, their tumor is growing and they're symptomatic, and that is when I would make a therapeutic switch. Sometimes we do a scan and the growth is minimal and they're not symptomatic, and maybe we would just watch them and not deliver a second-line drug. For the most part, the decision a little more clear-cut in the squamous cell patient population. I think any patient, whether they have adenocarcinoma or squamous cell, who gets platinum-doublet, in which we're not using immunotherapy in the platinum-doublet up front, the options second line are either single-agent immunotherapy with nivolumab, atezolizumab, or pembrolizumab, or docetaxel and ramucirumab, or docetaxel alone. I would say for the large majority of the patients with squamous cell, I would generally offer them, if I didn't offer them immunotherapy up front, I would offer it to them as second line. But there may be a patient that doesn't fit perfectly for immunotherapy. Either A, they have comorbidities that preclude them to getting immunotherapy, autoimmune diseases, so they're on steroids, or B, they may have rapidly progressing disease and their PD-L1 is 0%, like this patient. If a patient has rapidly progressing disease and their PD-L1 is 0%, it's questionable whether to use immunotherapy or docetaxel with or without ramucirumab. I would probably favor immunotherapy in this patient, but given the subset analysis we've seen from the REVEL trial, it's certainly a consideration to think about docetaxel ramucirumab. I think this decision process is going to go away very soon because immunotherapy is going to be added up front to platinum doublet for our squamous cell patients, so all we'll have left is the docetaxel with or without the ramucirumab. Certainly gemcitabine is another agent that could be considered. But I think for the most part, if I haven't used immunotherapy up front, I will use it as a second line. But for those patients, and again, which can't tolerate immunotherapy or have autoimmune diseases or are rapidly progressing and are symptomatic and have a low PD-L1, that may be a situation where I would consider, I'm not saying I would do it all the time, but I would consider a cytotoxic regimen with or without anti-angiogenesis.